fourth-year PGY-IV Resident, so we'll be completing the residency program in June, and July 1, you will become a fellow in our allergy program, which is a topic that is dear to his heart. So,
thank you, Dr. Daniel. All right, so today I'm going to talk about asthma. I'm really going to focus on just like the outpatient approach to treating asthma, not necessarily the inpatient or the acute approach to treating asthma. Because I picked this topic because I feel like a lot of the management that I've noticed in the outpatient setting, both in the medicine and the peds clinics, are a little off. They're not always right. So let's get started. So I have no disclosures. I'm not getting any money for this. So, all right. Some objectives that I would like to discuss are. First, we're going to define asthma and determine methods of diagnosis. We're going to identify common triggers for potential asthma exacerbations. We will recognize the various categories of asthma in order to treat them adequately and achieve treatment goals. And this is through all the age ranges. And then we're going to recognize current and novel treatment strategies for patients with mild to severe persistent asthma. So asthma, the prevalence is different from in many countries. It can range from 1 to 18%. In the United States, according to the American Academy of Allergy, Asthma, and Immunology, about 8.3% of children in the United States have the diagnosis of asthma. Establishing the diagnosis of asthma involves a careful process of history taking, the physical exam, and diagnostic studies. And differential diagnosis must be carefully considered, particularly in younger infants. As I will talk, that younger infants are a lot harder to diagnose asthma just because, there are many symptomatologies that it's really hard to distinguish. So what is asthma? So asthma is not a singular disease, but a complex. It's complex with different clinical phenotypes, which can present in an acute, chronic, and acute-chronic pattern. It is defined as a disease of airway inflammation, constriction, and of the smooth muscles around the airways. And this leads to mucus production, edema, and leads to airway trapping. This can lead to airway obstruction, like an obstruction pattern, which we see in patients, adult patients as well. When airways of asthma patients are exposed to environmental triggers, they respond to bronchoconstriction. This is described as like a hyperresonance, hyperresponsiveness. It is the top reason. And asthma is the top reason of missed school days. So in 2013, it was calculated that there are about 13.8 million missed school days reported. And this is just an example of like a normal airway and then an airway that you see in an asthma patient. So there are various types of asthma. The most common that we see is the allergic asthma type. Is the most recognized phenotype. Most often more seen in children, and you have to look at they have other diseases associated with, like eczema, allergic rhinitis. And they may have a drug or food allergy, and then if you were to do a bronch on these patients, you would see that they have high eosinophils, and these patients respond well to inhaled glucocorticosteroids. The non-allergic type you see mostly in adults and is not always associated with allergies. The cellular profile in the sputum, you may see an array of neutrophils, eosinophils, and some inflammatory cells, and these patients respond less to steroid treatment. The late onset asthma patients you see particularly in women and later in the adult life. These are they're not necessarily allergic types. They often require higher doses of inhaled corticosteroids, and they can be refractory to corticosteroids, so you may want to consider different treatment options. Asthma, when you have asthma with fixed airway limitation, basically you see these in patients with chronic obstruction pattern, and this can lead to airway remodeling. And then we often see patients with asthma as a cause of obesity. Like they may have problems breathing due to their obesity, and this can you see little eosinophils in their airway, but not necessarily due to an allergic response. So some epidemiology. Asthma is the most chronic type of chronic disease in children in resource-rich countries, so like the United States, Western Europe. About 8.3% of the United States, U.S. children had asthma in 2016. This was down from 9.4% in 2010 and about 8.7% back in 2001. The prevalence rates currently under asthma under the age of 18 is around 8.7 to 9.7% from 2001 to 2009. We often see increased prevalence in low-income families, especially patients living in the southern part of the United States. And you also see it, there's high prevalence in Puerto Rico and non-Hispanic Black children, particularly living in inner cities. And the onset is usually at the age of puberty. Boys have a higher prevalence than girls, about 9.2% versus 7.4%. So this is a map that I got from the CDC, and it shows about 60% of all children with current asthma have a persistent type of asthma, and I'll go into the different categories later. And about 40% may have like what we call an intermittent type of asthma, and these range from the about 25.6% in the Mississippi area, and then a 55% in around Oregon. So why do we care about it? Well, medical costs, asthma is very expensive. In 2013, patients with asthma, ages between 5 and 17, missed about 13.8 school days. And this was about 2.6 days per child. In 2012, the median cost of asthma was between $983 in the United States per person. This can range from $833 from places like Arizona up to about $1,000 in Michigan. And asthma accounts for about 14.2 million clinical office visits, about 439,000 discharges from the hospital, and about 1.8 million emergency departments every year. And children who were 4 years or younger were less likely to have asthma, but children in this age range were more likely to have asthma attacks, about 62.4%. Emergency department urgent care visits, about 31%, and hospitalizations, about 10%, when compared to children of older ages between 12 and 17. From 2008 to 2013, the annual cost of asthma was estimated to be about $81.9 billion. And this is looking at the treatment, the clinical visits, and the missed school days and missed work days. So this is one of the things, so morbidity and mortality, from 2001 to 2016, we saw that there was a decrease in asthma attacks about from 61 to 53%. But there were about 3,615 deaths in 2015, and about 219 of them were under the age of 18. Each day, about 10 Americans die from asthma. In 2015, there were reported 3,615 patients that died of asthma, and many of these deaths could have been avoided through proper treatment. It is estimated that adults are 4 times more likely to die from asthma than children. Women are more likely to die from asthma than men, and boys were more likely to die from asthma than girls. So asthma and influenza go together. You see a lot more patients that have asthma who would die from asthma are likely to die from the flu. So there are about 830 influenza-related deaths between 2004 to 2012, and then 16% of these subjects did have diagnosis of asthma. Between 2003 and 2009, about 32% of the 2,165 children hospitalized for seasonal influenza had asthma. And then I found this interesting, like with the H1N1 pandemic, about 44% of those children, about 1,160 children, had asthma. So this is why we like to vaccinate. One of the main reasons why we like to vaccinate. So the CDC recommends universal annual screenings to reduce influenza-related deaths, especially in children with asthma. So if you see a patient in clinic, always bring up vaccinations. It's very important. And then we also make sure we always vaccinate our patients with chronic diseases, such as cardiopulmonary disease, pneumonias, bronchiolitis, sepsis, or bacterial infections. And this is a cool picture I found of influenza. So when you first meet a patient who you suspect asthma, what do we do? What are some of the things we need to ask? So the initial patient encounter, you want to get a diagnosis of asthma. You look at their symptomatology. You look at their day-to-day living, how many times they have exacerbations, and all this. And then you want to assess their severity. You want to look at how they're using their medication, and then you want them to show you how they use their medication, and then try to reinforce that. You want to write down an asthma action plan, and then you want to schedule appropriate follow-up appointments. And these can range between 3 months to 6 months, depending on how well they're controlled. And then in the interim, when you have these follow-up visits, you always want to assess their control. You want to always look at their techniques, look at any side effects from their techniques, and talk about environmental controls. There are many triggers to asthma, which we'll go over later. You want to maintain step-up and step-down therapy, which is the way that we titrate medications depending on their particular category of asthma. And then review their action plan, and then make sure they have appropriate follow-up visits. And this is a continuous process. Asthma is a chronic disease. They may grow out of it, and they may not. So you just got to keep reinforcing, proper technique and proper medication administration. So what are the common symptoms? So in children, about 80% of children who have asthma develop symptoms before the age of 5. But it is often frequently misdiagnosed, especially in younger children, in the infants, in the toddler range. Coughing and wheezing are the most common symptoms in childhood asthma. You may also see breathlessness, chest tightness, pressure. Chest pain has also been reported. You may see patients who, if you should see a patient who is doing bad in school, they could be an undiagnosed asthma. If they have more sleepiness, if they're more tired during the day, they may have asthma. And they have like nocturnal symptoms. They're waking up at night. They're coughing at night. You may want to think about asthma. And then they may have certain exposures to certain things, like they may get tired or short of breath because of cold air, exercise, laughing uncontrollably, just random crying in little patients. You may see that. So so wheezing is common in asthma. You hear that a lot, but not everything wheezes is asthma. So what is wheezing? So it's a high-pitched musical sound produced by the lower airways for narrowing of the airways. The wheezing in asthma tends to be polymorphic and different pitched. Airflow obstruction becomes severe, and wheezing can lead to both high inspiratory and expiratory wheezing. But initially, you would hear the expiratory wheezing. But then if it gets too severe, you may hear it in both the inspiratory and expiratory phase. In contrast, we see a lot of patients with this. In harsh expiratory monomorphic wheezing, you may want to consider tracheal malacia in these patients. And then if you have an upper airway obstruction, you may want to consider vocal cord dysfunction, especially if they have inspiratory monomorphic, like a single pitch wheeze. And this can be audible during an exacerbation attack. So I have a video, and it didn't work. Like musical variable. If any of the students rotate in our peds clinic and you see Dr. Red patients, you may hear this sound, especially in little kids who are very skinny. It may be a lot harder to hear it in more larger children, but it's very common. Okay, so like I said, not everything that wheezes is asthma. Some of the things you want to consider If you notice a sudden onset of symptoms, you want to think of a foreign body. Little kids always pick up things. They always swallow things. You know, when they develop their pincer grasp, they just want to put everything in their mouth. So something to consider. Coughing, choking when eating or drinking, you want to think of oropharyngeal dysfunction with an aspiration. If you see patients with poor growth, low body mass index, families with a history of sterility in males, or chronic rhinorrhea, recurrent infections, you want to think of CF as a common differential. And of course, you have your immotile ciliary dysfunction. Acute onset with a history of asthma as a teenager, you want to think of vocal cord dysfunction, which is very common, which I'll talk about a little later. Chronic wet productive cough, you want to think of bronchiectasis. And if you patients that you notice that have recurrent infections, recurrent sinusitis, recurrent pneumonias within a year span, you want to think of some kind of immunodeficiency. So vocal cord dysfunction is often very is confused with asthma because it has a lot of the same symptoms and a lot of the same triggers of asthma. So what is it? It occurs when the vocal cords do not open appropriately in the process of breathing. So this is a picture that I found in a patient with vocal cord dysfunction, and as you can see, the vocal cords are in the adjunctive position in the patient that is actually trying to breathe in. So that's going to be hard for them to take in the breath. And these muscles tighten, and this can lead to coughing, wheezing, voice changes. Vocal cord dysfunction is a cause. They often have a problem breathing in as opposed to asthma when they have a problem breathing out. And how we diagnose this, we can do spirometry, and you may do a laryngeoscope to actually observe the vocal cords during the different phases of breathing. And then treatment really is speech therapy and breathing techniques, teaching the patients to breathe and calm down, because a lot of these triggers happen when they're in an excited phase or a particular trigger happens. So, can anyone think of any triggers of asthma? Any students? Reflux, yeah. What else? Okay. Anything? No? Smoking? Yep. All right, yeah. So a lot of things trigger it. Let's go over some of them. So common triggers, we have a big one is dust mites. This is a picture of one in very, very nano microscopic. Right, so dust mites, animal dander, pollens, cockroaches, cockroach droppings can trigger asthma. Smoking, we see a lot of families that have adults that smoke in the house with a little kid that may have asthma. That's why we always tell them, don't smoke in the same room as these kids. Put a smoke jacket on. Smoke away from all the children. Keep away all the smoke. So it's very important. Air pollution. Strong odors, perfumes can lead to asthma triggers. And then we have exercise, which, you see these patients that only have symptoms during exercise period, and then we call this an exercise-induced bronchoconstriction. And with these patients, you really treat them with you tell them to pre-medicate, give them a puff before they actually go exercising. You see these a lot in kids and even adults. And then certain medications have been known to worsen asthma symptoms, including aspirin, NSAIDs, like ibuprofen, and even beta blockers. This is a picture of ragweed. So this is why when we have patients that we see in clinic, we also want to talk about environmental controls, making sure they clean up, and they have dust mite controls, especially if they have a known diagnosis of these particular allergens. Some other triggers, anxiety, stress can lead to asthma triggers if they have, and viruses, bacterial infections. That's why we talk about when kids have RSV, they have an influenza, they have a rhinovirus. A lot of these can trigger these asthma symptoms. Exposures to cold and dry air, weather changes. You often see these as seasonal changes. And then patients with acid reflux, heartburn can lead triggers to asthma. So when you have a patient and you want to actually get an official diagnosis, what do we do? So the National Asthma Education and Prevention Program expert panel recommends performing spirometry in patients above the ages of 5 years or older if you suspect it. Not all 5-year-olds are the same. They may or may not be willing to blow into a machine to get you a trigger. So it really depends on their maturity level, honestly. And then you want to look at airflow obstruction, and especially these values, the FEV1, which is defined as the air you breathe out in 1 second in a reading. And this is like pretty important measure that we look at. And then in a patient who, if there's significant reversibility of an FEV1 over 12% from baseline after you give them a puff of albuterol or any bronchodilator, that's considered they probably have asthma. We can diagnose them as asthma. There was a study done in 2013 that showed that using a cutoff of 8% is better in younger kids because of the different variability in children. The FEV1 measurement and the pulmonary measurements are really dependent on the patient's age, their height, their ethnicity, and it's all like in charts and everything. And then the spirometer is calculated to test these things. When you have patients that come into clinic and we want to do spirometry, you do at least 2 to 3 testing, and then the machine calculates the best out of all of them in an average. And it's pretty cool to watch. And then the forced vital capacity, this is the largest amount of air that you can forcibly exhale in one breath. So that's all the air in your lungs, besides the residual volume that you keep in your lungs. So, does anyone actually know how to read one of these? No? Besides Dr. Kiligo. All right, so so this is what we call a flow volume loop. So you have here on this axis, you have the flow calculated per second, and then this is the liters. And you notice that there's always a little bit of room right here, and this is what the residual volume. This is the volume of air in your lungs at all times. And then 2 things we look at. We look at the FEV1 to FVC percentage, and this is calculated into predicted, and then the actual of what the machine actually measures. And then you look at the FEV1. So in this patient, this is the expiratory phase and then the inspiratory phase. So patients take a deep breath in, and then they blow out as hard as they can and try to do it in 1 second. And then it comes down back to their inspiratory phase. So if you look at this, in this patient, you can see that the ratio they got for the FEV1 over FVC is 68%. So what is a normal one? Does anyone know what a normal ratio is? No? 80, yeah, 80%. So anything around 80 is good. We consider anything less than 70 to 75 considered an obstructive pattern. And then looking at this particular curve, you can see there's a kink here. This is a classic pattern for an obstructive pattern. And you see this in patients with asthma. You also see it in older patients with COPD. So this red line is before we gave this patient any bronchodilator. We give them bronchodilator, and all of a sudden the curve goes up to here. So this is the actual what they got, and then after, and then this is the percent change in their FEV1. So it's 30% change after we gave them the medication. So does this patient have an obstructive pattern? Yes, of course. So we said that anything changes in 12% is considered an obstructive pattern. So we can safely say that this patient, based on their symptomatology, based on this diagnostic test, they have asthma, right? So what about the younger kids, kids less than 5 years old? So it's a lot harder to diagnose in this age grade, and you really have to look at clinical judgment based on the patient. You may want to give them medications. You can give them like albuterol, like a neb. They won't be able to use a spacer because they're too young. So you want to give them a little mask and a nebulizer. And there is ongoing debate in the community about how to actually categorize these patients. A lot of physicians use the term just asthma, just call it asthma. I noticed here that we like to use reactive airway disease as a term. Also, we have wheezing bronchitis, asthmatic bronchitis, wheezing associated respiratory illness. And you see this a lot in kids who have these chronic, they always get like viruses and they come into the clinic wheezing, we give them a treatment, they feel better, then they go home. So, but they may necessarily not have the diagnosis of asthma. So another thing to consider in this patient age group is you have a kid that comes in with unexplained chronic cough, and chronic cough in a young child is a common symptomatology for patients with asthma, and it's often misdiagnosed. So this is the Asthma Pediatric Index, and this was developed in the year 2000, and it was used as a clinical tool to diagnose kids less than 3 with. It's not necessarily to diagnose them, but to see the predicted pattern of them developing asthma in a later in life. And we have 2 criteria for this. There's a stringent criteria and then the loose criteria. The stringent is 3 episodes of asthma per year during the first 3 years of life, and then you have 1 major and 2 minor. So the major is you have asthma that is documented in a parent, and then a patient that has a history of wheezing. Minor criteria, they may have allergic rhinitis, they may have wheezing, but not necessarily with when they have colds. And then if you were to do a CBC and you see eosinophils, yeah, it's a possibility. And then you have the loose criteria, which is 3 episodes of wheezing per year, and then you have 1 minor and then 1 major and then 2 minor. Children with we look at this with a loose index were 2.6 to 5 times more likely to have active asthma between the ages of 6 and 13 than children with a negative loose index. Risk of subsequent asthma increases from 4.3 to 9.8 times more likely when you look at the stringent criteria. So this is really just a tool that clinicians can use to predict younger kids less than 3 for them to develop asthma in the future. And then we can do some education. We can talk about maintenance therapy and how to avoid flare-ups in these kids. So another way that we could diagnose asthma in a clinical setting is the Methacholine challenge test. We don't really see this a lot. I haven't really seen it here. So what is methacholine? It's a non-selective muscarinic receptor antagonist. And then these are the different bioconjugulations that we can give. You want to determine the FEV1 within 5 minutes of the challenge. And then with this, a positive change is over 20% reduction from their baseline FEV1. And then you want to give them an albuterol right after the challenge so they can release symptoms. Because these patients may have, you can get a dizzy feeling, you can feel uncomfortable. You always want to watch these patients closely in the clinic. You don't want to push them into an asthma exacerbation in the clinic. Some of the contraindications to this test, if you do their spirometry and they have a low function, like they already have a low FEV1 to FVC, or they have a low FEV1 in general. And you don't want to do this. You don't want to do this challenge in adult patients who have a history of stroke in the past or a history of heart attacks in the past. So, indications. So, patients who present consistent with symptoms consistent with asthma, but with the normal pulmonary function sense and no response to bronchodilators, you can use the methacholine challenge. If they have atypical symptoms like bronchospasms that are not associated with asthma, patients who present with symptoms that result from asthma, but it's ill-defined, so it's not necessarily, you can't really say that it's asthma based on their symptomatology. And then if you suspect an occupational asthma, a reactive airway dysfunction, or irritant-induced asthma. I found these some other indications. So patients who want to go scuba diving, you may want to use military personnel. You may want to consider this provocation testing. So I found this article, and this was trying to see if the methacholine challenge was a good idea or if it was a good way to diagnose patients with asthma. And this was published in the Journal of Pediatric Pulmonary in 2008, looking at the responsiveness of methacholine challenge in children. And what it really concluded was that girls who have atopic findings and non-atopic findings, meaning they have a history of allergic rhinitis, they have a history of eczema, this was good to use in girls. But in boys, it's good you can use this in boys who have a history of eczema, but it didn't really show patients who have boys who didn't have a history of non-atopic findings as a good way to actually diagnose these patients. So, classifications and treatment regimens. Switch gears a bit. So, like I said, when we see these patients in clinic, we want to determine if they're using their proper technique to use their inhaler. So I have some videos about proper techniques. I have an example of bad technique and then good technique.
Mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So, bad technique. Yeah. So I found this video from the CDC on their asthma control program, and it was actually pretty good. So this shows you how to use a proper inhaler in a kid with a spacer.
With a spacer. Take off the inhaler cap and make sure the mouthpiece and spray hole are clean. Shake the inhaler 10 to 15 times.
I don't think it'd be like that dramatic.
Put the inhaler mouthpiece into the end of the spacer. Inhale a deep breath and breathe out all the way. Hold the inhaler and spacer between your pointer finger and thumb. Put the mouthpiece of the spacer in your mouth and above your tongue. Close your lips around the spacer. Tilt your head back a little bit. Press down on the inhaler one time and breathe in slowly and deeply. Breathe in all of the air you can and hold for 5 to 10 seconds. Open your mouth and breathe out slowly.
I don't know if the little kids would do it that slowly, but, that was pretty good. All right, so there are many inhaled corticosteroids that we have a combination of, and there are many options that we can choose from. So how do we know which medications to start and which is appropriate for different age groups? So you may have seen this in clinics, especially in a peds clinic, allergy clinics, pulmonary clinics, and there are a lot of options for our short-acting. We have a lot of long-acting beta agonists, inhaled steroids, and a combination of an inhaled corticosteroid with a long-acting beta agonist. And then we have our anticholinergic medications, such as like ipratropium. So let's figure out how we can classify these different patients and what regimens we can use. So in the category between ages 0 to 4 years of age, this table shows how can we classify them. So if they have intermittent asthma, they may have symptoms maybe less than 2 days, 2 times a week. They may have 0 nighttime awakenings. Maybe mom gives them like albuterol, maybe like less than twice a day, and then doesn't really interfere with their daily regimen. And then you want to like either consider like a step 1 or step 2 approach for the different classifications. So let's go into the steps. So this is very useful. So this is what we use for step up, step down therapy in this age range between 0 and 4. So you may want to start them in a step 2, depending on the previous chart. You want to start them like being a low dose and in corticosteroid in the step 2 pattern. So how do we know when we should step up or when we should step down? So for each of these age groups, if they have symptomatic control in a 3-month period, we may want to consider stepping them down. But if they don't, we may want to consider stepping them up. So that's really when you want to like see these patients in like follow-up visits. So this is the classifications between ages 5 and 11, and in this, at this stage, we can actually use our spirometry or FEV1 measurements in this patient in this class, because if the kid is mature enough to actually do this, we can use the FEV1 to classify them. If they're intermittent, they may have a normal FEV1 between exacerbations. They may have, if they're mild, it's between around 80, but they're not really showing any obstruction. As we get into later, they may have like some form of obstruction. FEV1 may be less than 60 in the severe case. And then the difference between this age group and the prior age group, that the nighttime awakenings are different. Intermittent phase, they may have less than 2 per month, 3 to 4 in the mild. They may have it weekly, 1 time per week, but not nightly in the moderate, and then often 7 times a week in the severe category. So this is the step up, step down, and then at this stage, we can start thinking of giving these patients leukotriene receptor antagonists or singular montelukast in this age group. So as we get older, we start doing patients 12 years or older, and pretty much 12 years or older is you can use this chart for our adult patients, and it's very similar to the previous group. And at this stage, we can consider other modalities of treatment. So an example, like your step 2, you still consider the inhaled monotherapy of corticosteroids. Step 3, inhale plus a LABA, and then you start increasing your steps. And then always with these patients, for every visit, you want to check if they're using their inhaler appropriately, checking environmental triggers to see if they're avoiding them, and then also considering stepping down if the symptomatology is if their asthma is controlled in a 3-month period. So patients could be in let's say they have a history of moderate persistent asthma, but you have to look at it if they're controlled or uncontrolled. So that's a good way to define these patients. So how as clinicians do we get these patients to actually use their inhalers appropriately and appropriate times? Does anyone have any ideas? What do we do in clinic? Spacer education. So what's another thing we do? You can use the asthma action plan. Yay! So this is a tool that was developed that patients can use at home and in the school setting. We want to keep these patients in the green zone. This is what they should be taking on a daily basis. Let's say they're on their Singulair, or they want to use their albuterol like as needed, or when they're about to do exercise. You want to keep them in this range. This is when we start doing the yellow phase is when they start having symptoms like coughing, wheezing, chest tightness. Okay, you want to right here, use your albuterol like this many times until you have symptom relief. We want to avoid patients in this range. This is when they have trouble breathing, wheezing, they becoming tachypnic, and then you don't want them to tire out because that would just lead to all kinds of bad things, and they may end up in the ICU setting. So you want to try to try to go over the asthma action plan at least with every visit. So what are our goals of treatment? So the main goal of our treatment is to reduce impairment, and impairment is defined as the intensity of symptoms which can lead to limit patients' daily activity. Specific goals is to reduce the symptoms of asthma, the cough, the chest tightness, the wheezing. You want to minimize the need of their short acting, at least less than 2. So you want to try to keep them in an intermittent category. When you reduce the nighttime symptoms, you want to optimize their lung function, and you want to maintain their normal daily activities, such as schoolwork, school performances, athletics, exercise, and then seeing if like patients are and families are happy with their regimen. So this was a large trial that was done. This was the Childhood Asthma Management Program, or the CAMP trial. This was started back in the early 90s. And the purpose of this was to evaluate long-term anti-inflammatory therapy when comparing the course of asthma. Particularly, they wanted to look at their lung function, the bronchial hyperresponsiveness, their development, their physical outcomes, and all sorts of things. This was a pretty long, comprehensive trial, and it looked at the first 2 years of enrollment. There were about 1,041 patients between the ages of 5 and 13, and they either gave them a budesonide twice daily, Methacholine, which is a mast cell stimulator, or a placebo. So this was a long prospective trial. So they use about 1,041 children. About 32% of these children were ethnics, or also African Americans, Hispanics, ages 5 to 12 at the time of screening. They looked at their lung function, their FEV1, and they observed them initially over a 5 to 6 year period. And then after that initial observation trial, they looked at these patients over 13 years. And actually, the trial is still going on. They're still looking at these patients. And then the average age of these patients since the early 90s is about 25 years now. So right when they were like 5 to 12, up to the age of 25. So this is basically what I just mentioned in the outline. So they had the initial visits, the 3 visits per year, and then 2 visits, and then they would follow their PCP. They would get their important regimens, measurements, or height, weight, anything like that. So the National Heart and Lung Blood Institute Childhood Asthma Management Program, the CAMP trial, is the largest and longest running trial in children from mild to moderate asthma. So one of the interesting things, they looked at the actual effects of chronic inhaled corticosteroids and the use of oral steroids in patients treating with asthma, and is the only prospective longitudinal study started from child to adulthood. And then the second component of this trial was to look at inhaled steroids and other parameters. So what did they conclude from this trial? So they concluded that starting between the age of 5 and 13, management of mild to moderate asthma was associated with a mean height deficiency of 1.2 centimeters, which was only observed in the first 2 years of treatment. This was dose dependent and did not decrease, and it was not progressive and cumulative into adulthood. CAMP investigators established that long-term use of inhaled corticosteroids at low, medium dose over 4 to 6 years was safe in children. Although it did cause a small increment in their height, it was not progressive in the first years of life. Although inhaled corticosteroids reduced the risk of exacerbation, it did improve symptomatology, but overall base lung function disappeared after the patients stopped their inhaled steroids. There was a small decrease in bone marrow density, especially in boys, but it was only cumulative with ICS dose and it was not associated with any osteopenia. There were no risk of fractures in these kids, and that was found with either the oral steroid or the inhaled steroid. And this was actually done. Was observed with follow-up DEXA scans in these kids. So they recommended that patients who are on inhaled steroids should have close follow-up and looking at different patterns and their impairment and severity. So I thought that was a really interesting trial when I looked it up. So this was another trial, and so that was looking at the why we use the monotherapy of inhaled steroids in these patients, and this looked at 284 children between the ages of 6 and 14. They looked at their FEV1 measurements, and they either gave them fluticasone monotherapy or the combination therapy. And this combination therapy was with the Singulair and Alaba with inhaled corticosteroids. So what they found with this was that the monotherapy was superior than the combination therapy. So this is why in the previous slides, when we talked about the categorizations, the step 2, you want to consider the single monotherapy of the inhaled steroids. And this trial was actually published in the Journal of Clinical Allergy Immunology. So another trial that we found is the SMART trial, and it's a multicentric research trial that looked at the using solumeterol, which is a long-acting beta agonist, and it looked at patients, about 26,000 patients in this trial, which was done back in 2006, and it was published in the Journal of Chest Physicians. So they separated these patients between the solumeterol and then a placebo, and it was a randomized, double-blind, placebo-controlled trial. But this trial was actually stopped abruptly because they noticed that there was a significant increase in respiratory-related and asthma-related deaths with the patients who were on receiving the solumeterol alone. Salmeterol. Salmeterol alone. So this is why we never give the long-acting beta agonist alone. So when do you want to refer to a specialist, either a pulmonary or an allergist? The patients, you want to do it when patients who experience life-threatening asthma exacerbations, patients who require frequent hospitalizations or multiple doses of steroids, patients, adult and pediatric patients older than 5 years of age requiring step 4 therapy, and patients, and then children under 5 requiring step 3 therapy. When you notice that the asthma is not controlled in a 3 to 6 month period with frequent follow-ups, a patient appears to be unresponsive to therapy. Maybe they have some underlying condition such as nasal polyposis, allergic rhinitis, ABPA, or vocal cord dysfunction. If they need additional testing like skin testing, bronchs, or pulmonary function tests, or they may be a candidate for allergy immunotherapy, or if they may be a candidate for biological therapy. So what are biologics? These are therapeutic. They're either man-made or they are produced or they're produced in nature. And biologics, they usually target a particular gene or a protein. And biologics are used in cancer treatment. They're used in all forms of medicine. And we have a lot of biologics are not a new thing. We have biologics like insulin, growth hormone, red blood cell stimulating agents are all biologics. So in asthma treatments, you want to really consider biologic therapy after the age of 12, because a lot of these, or in this case for Xolair at 6, this is for the severe persistent group of patients. So Xolair was produced, it is actually a omalizumab, which is a monoclonal antibody that binds to IgE, and this is really for patients with severe persistent asthma with positive skin testing. It is given 1 to 2 subcutaneous injections every 2 to 4 weeks. Some of the side effects you see are muscle aches, fatigue, injection site reactions, and this is really for the kids with the allergy type of asthma. And then Nucala is another agent. This is a monoclonal antibody that binds to IL-5, which is a major cytokine in growth, differentiation, activation of eosinophils. So this is another one that works for the allergy phenotype of asthma. This can be given as a sub-Q every 4 weeks. And then common side effects are headaches, back pain, injection site reactions, and then the rare severe allergic reactions. And then one of the newer one is Fenestra, which is another agent that binds directly to the IL-5 receptor on the actual eosinophil. This is for patients over the age of 12 who have the severe eosinophilic type. This actually induces apoptosis of the eosinophil, so it actually just clears them out of the blood altogether. And then with any of these, you want to have the patient in clinic. You want to monitor them for any side effects, and initially for at least a 30-minute period. And then you have your common side effects, headaches, or any allergic reactions to this. So this is another one, but is not indicated right now for patients less than 17 years or younger, and it works very similar to Nucala. So other possible treatments that we could consider that I found interesting. So what about probiotics? Can they help at all? Well, maybe. So this was a meta-analysis, a randomized placebo-controlled trial looking at giving probiotics in the prenatal period and see if these patients will have asthma in the future or any atopic findings. And what they found with this particular meta-analysis, that the probiotics were effective in reducing IgE in these patients, but did not significantly reduce the risk of atopic sensitivity. They found that lactobacillus, compared to other strains, actually increased the risk of atopic findings in these patients. And administering probiotics may reduce total IgE and protect atopic sensitivity, but does not necessarily protect in the development of asthma. So they mentioned that further trials are needed to look at different strains of probiotics and see if these particular if this is a potential preventative effect. I thought that was interesting. Another possible treatment in the future is macrolide in kids, and this I found was a common research article that I found using macrolides. There were about 1,415 patients, and in this systemic meta-analysis, they looked at using azithromycin treatment can reduce the need of short-acting beta agonists, but they found that they needed additional randomized controlled trials determining the actual dose of macrolides in kids. So they found that it does reduce the need of patients with asthma because macrolide in itself is an anti-inflammatory, but we still need data on what dose they need, how frequent they need it. This was very similar to an adult trial that was published in 2016 called the AMAZES trial, and that looked at macrolide use in adults. So asthma and vitamin D, I've noticed, had a lot of, with my research, there's a lot of research in using vitamin D as a possible preventative measure for patients with asthma. They found that vitamin D deficiency was highly prevalent in atopic patients, pediatric patient, and is also distributed through the immune system. And then vitamin D receptors are seen in all parts of the body, especially in the immune system. And then several studies suggest that the need for screening for vitamin D deficiency in high-risk pediatric patients, particularly in African Americans, Hispanics, and children with obesity. So we want to assess these. You want to assess kids with vitamin D deficiency who have asthma. So I found there was a lot of studies looking at actual vitamin D deficiency in kids. One study showed that between the ages of 3 to 8, and looking at kids with asthma and kids with not asthma, there were a lot more kids who had asthma also had a concordant vitamin D deficiency. But vitamin D deficiency does not always correlate with the presence of asthma. And vitamin D has also giving vitamin D to kids who have asthma has been shown to increase the responsiveness of steroids and steroid resistance. So this was a study done overseas in Tehran, was a randomized clinical trial looking at 130 individuals and measuring outcomes with budesonide and kids with vitamin D deficiency. And what they found was giving vitamin D supplements was associated with better asthma control and improvement of the FEV1 in patients with mild to moderate persistent asthma in a 24-week period. So I thought that was pretty interesting, but we don't have any current recommendations for giving vitamin D in kids to prevent asthma. These are the current recommendations we have for kids. This is according to the American Academy of Pediatrics, but we still don't. The data is still insufficient of treating kids preventively to prevent asthma in the future. So Tuesday, May 17, 2019 is World Asthma Day. Yay! So we'll just have a big party. Yeah, inhaler for everybody. Here's some of my resources. Thank you. Any questions, comments?
Nice job. It was a really nice presentation. Questions or comments?